This is Reed Lance Rosenthal on the Right Side Radio. Happy Saturday across the Rockies. KGAB AM 650 and the Town Square Network and Easy FM 101 Colorado Springs, northern New Mexico, and the Monster 780 AM Denver. Hello Montana to New Mexico and Nebraska to Utah. Got a great treat for you. This is our continuing series of 3 shows on Obamacare, the Affordable Care Act. And last week, if you remember, you can go back in the archives, and that's on the rightsideradio.com. And I interviewed great economist Kimberly Amadeo, and she was kind of on the fence on this law and kind of wanted to stick to facts, which was terrific. And next week, I'm interviewing an opponent of the law. This week, I'm interviewing a guy, some of you may have heard his name because he's a big blogger. His name is Timothy Jost. And Timothy has a JD. He is highly involved in the healthcare industries. He graduated cum laude from the University of Chicago and has all sorts of honors. His blog, by the way, is healthaffairs.org/blog. That's healthaffairs.org/blog. We'll give that to you later in the show, too. And just so that you guys kind of know where the setup is here today, Timothy likes this law. He's not a fan of the law. There's a difference. But he likes the law because he believes, and I'll let him tell you in his own words, that probably no other law is going to come along, so we ought to try and make this work, and it does accomplish some good things that he would like to see accomplished. Is that a fair summary, Timothy? And welcome to the show.
Thank you, and thank you very much for inviting me. I think that is a fair summary of my position. Let me just clarify, though, quickly that the Health Affairs blog Health Affairs is the country's leading health policy journal, and I'm just one of many people who blog there. But what I do blog about is every time there is a new regulation, a new guidance, a new court decision, I try to explain it in sort of nerd lay terms so that people don't have to read the whole 600 pages. They can just read my blog and figure out what's there. So it may be more technical than some of your readers would be interested in, but for some of them it may be just right.
You betcha. And you know, at that site, I'm looking at it right now, you can find lots of different opinions, folks. They're more scientific. But, you know, it kind of a great non-left, non-right place to go and balance out opinions, because it's looking like, to me, there's people of varying opinions. And and also, Professor Jost he's a co-author of a case book called Health Law, and your specialty in teaching, Timothy, is health law, right?
That's correct, and we just put out...
So, you know, we're talking with kind of an expert on this, and he needs to be an expert because we got 2,700 pages of bill, and then we have 20,000 pages and growing of regulation. And Timothy, I don't envy you trying to figure that all out.
Yeah, although it's a little bit of an overstatement. The 2,700 pages was really big print, but the regulations, I've read every regulation that's come out under private insurance and Medicaid parts, and it's nowhere close to 20,000 pages. Now, if you include all of the Medicare payment regulations, which come out every year regardless of the Affordable Care Act, you may get closer, but I don't think we've had 1,000 pages of regulatory text. Now, lots and lots of explanations, but but there's more there than anybody wants. So, yeah, I agree with that.
Absolutely. Well, first of all, let me ask you just on a big picture, and then we'll get down to some nitty-gritty, because I think this is a rare insight for my audience up and down the Rockies. First of all, what do you like about this? I mean, give me the 5 top things you like about Obamacare.
Well, maybe I could narrow it down to 3, but they're awfully big ones. When people talk about health policy, they usually talk about the big 3, which are access, cost, and quality. And as I think everyone knows, we have by far the most expensive healthcare system in the world, far more than anybody else spends on healthcare. If we would have spent the same amount on health care as Switzerland, the second most expensive country, has spent on health care over the last 30 years, we could have balanced the budget and had a $3 trillion surplus. So that's how much we spend on health care. Second is access to care, and that is another big problem in the United States. Every other developed country, people have access to some kind of health care financing on the public side. We don't in the United States. For about 55 million people who are uninsured, have either private or public health care coverage available. And then the third is quality. And there we do reasonably well, but we really don't do as well as many people think we do compared to other nations. The Affordable Care Act really concentrates on access. The main goal of the Affordable Care Act was to cover not all of those 55 million, certainly not the ones who are undocumented aliens, but to cover a large percentage of them, and in particular to cover those who cannot afford health insurance or who were closed out of the market because they had pre-existing conditions. So that's the thing I like most about it, is that it really makes a huge down payment on opening up health care, access to health care for millions and millions of Americans. On the cost side, not so much there, but we just had a report released today that employment health insurance premiums for employers grew only 4% this year compared to 9% in 2011. So we've been seeing, and healthcare cost increases have been at really the lowest level in my lifetime, well, at least in the last 40 years or so, for the last 3 years. Now, not that a lot of that has nothing to do with the Affordable Care Act, but the Affordable Care Act is part of it as well. And quality, there's a whole title of the Affordable Care Act that deals with quality of health care, and there's lots of different provisions in the Affordable Care Act trying to encourage high-quality care. And I think there it's going to make a difference as well, although it's harder to measure. So there's a lot in this statute to like, I believe.
All right. Well, let's start with access.
Mm-hmm.
You've read the Internal Revenue Service study from 3 or 4 months ago, correct?
Which study would that be now?
Well, so it's the latest one that they came out with, the latest, greatest. It's a study in which they specified that approximately 30 million people would not be covered, and we're not talking about illegal aliens, and that 7 to 9 million would lose by 2020 their current policy or current care provider. That study.
Now, do you mean the Congressional Budget Office?
No, I'm talking about the Internal Revenue Service. Pretty interesting report. You can look it right up at irs.gov.
Uh-huh.
Just type in health services and health report and health study. It'll all come up. So if we have 25 million people, we'll use your number of 55 million. We have 30 million that the government itself will accord them every degree of truth and honesty, particularly the IRS, that 30 million are not going to be covered. So basically, we're revamping the healthcare system in the United States to cover an additional 25 million people who are not covered right now, some of them by choice. Is that a fair summation?
Some of them by choice, a lot of them not by choice. Now, a couple of things on that. One is the number that are going to be covered under the statute has dropped fairly significantly because of the Supreme Court decision. The way in which the statute was originally structured, many millions of people were going to be covered under the Medicaid program, basically everybody below 100.
Well, basically they would be covered in the state exchanges, but under the 10th Amendment, the Supreme Court said that the federal government could not usurp state authority in setting up the exchanges.
That's not quite right. What the Supreme Court said was that the Supreme Court really didn't rule on the exchanges at all. What the Supreme Court held was that the federal government could not require the states to expand their Medicaid programs. So about half, including some of the states with the largest uninsured populations, have decided to do that.
Sure.
So what you're going to have...
Well, 6 of one, half
billions,
of the other.
Well, no.
I mean, a state has a choice right now to become involved in the exchanges, expanding the Medicaid.
That's been true all along.
Okay.
Yeah.
Well...
But they do have now the choice not to expand Medicaid and still stay in the program, and that's going to leave millions of people uninsured because not quite a number of states, including some of the states that you cover, have decided not to cover those people. And so that means millions of people who would have been covered under the statute, and the people who really need it the most, the people who are the poorest.
Now, under the law, Timothy, some of those states decided not to. I mean, there are many different reasons in various different states that they're in or they're out. But the bottom line is many states were concerned about the fact that the 90% reimbursement, so that the audience understands, give or take 90% of the costs of the state in enrolling in the program and expanding Medicaid via the exchanges that you all heard about on TV, was going to be reimbursed by the federal government for, I believe, a period of 3 years.
It's 100% for the first 3 years, and then it phases down to 90% by 2020.
And what happens after 2020?
It stays at 90%, which is far more than what the states are reimbursed. And right now, it's between 50 and 80%, depending on the state. So it's a far higher rate of reimbursement.
And I'm going to come back to that point a little bit later in the show. So everybody kind of jot it down, and that's at 90% reimbursement to the states. But, in terms of access, would you agree that it's not the insurance card, that little plastic card that says you're covered by insurer, the insurance company XYZ? I mean, that's not what makes you better, right?
Well, actually, there's lots and lots of data, lots of studies that have showed that the uninsured actually do have worse health. They have shorter lifespans. They get sicker faster.
No, well, you know what? I agree with all that.
Yeah.
However, the card is not what administers care to you.
That's correct.
It's the provider.
That's correct.
Okay, so right now we have a doctor, and you can read the AMA, you can read this study, that study, left studies, right studies. Bottom line is, give or take, we have a shortage of about 50,000 physicians in the United States right now. Some say as high as 68, some say as low as 34. But somewhere in that realm, we're short doctors. Do you agree with that?
No. We are short on, we are developing a shortage of primary care physicians.
Okay.
We don't have a shortage at all of specialists, but I would agree that we do have a shortage of primary care physicians, and it is growing as people get older, and again, as I think you're about to say, as more people get health insurance. Well,
and as more doctors drop out of the business. I mean, I happen to have 4 personal friends who are doctors, who one is retiring this year, the other 3 retired the last year. One retired right after the ACA was passed because of the ACA. So there's no incentive in the ACA to train new doctors, right?
That's not true.
Well, tell us about that.
There's a whole title in the ASA on workforce, and there are provisions in there for scholarships, there are provisions for residencies, there's provisions for loans, and in particular focused on primary care. And there are additional Medicare and Medicaid payment incentives also for primary care. There's also provision in the statute for training other non-physician healthcare professionals, because what we really need in this country is to have more nurse practitioners and physicians' assistants doing work that physicians are doing now that they don't need to do. Physicians ought to be working at the top of their license on the kind of really difficult cases that they're trained to deal with. And when my son needs or somebody needs a sports physical, or when someone comes down with a cold, they shouldn't have to see a physician and tie up their time. And the Affordable Care Act, in fact, does have a whole title on workforce. Now, it hasn't been fully funded by Congress, but it's there.
Well, we're going to get into cost here in a little bit. I mean, the bottom line is the bill's not funded, period. Well, I mean, we'll talk about that. But in the workforce provision, number one, what is the goals for primary care physicians in that workforce provision?
Well, I mean, the goal of the workforce provisions are to get primary physicians trained and into practice, and then, of course, then their goal is going to be to improve patient health and to cure illness.
Right, and most primary care physicians, I mean, it's pretty expensive to become a doctor.
Right.
I mean, this is not a cheap education.
That's true.
Would you agree that, you know, somewhere
90% of it is paid for by the public, too, which is a fact that people don't often know. That's from AMA statistics, 90 to 95%.
Right, and
Medicaid,
about
Medicaid through insurance.
But the cost to the person who wants to become a doctor is somewhere between $75,000 and $200,000, depending upon what schools they attend.
Right.
Okay, so you know the AMA, the ACA provides for loans for somebody who wants to become a doctor, correct?
Yeah. I mean,
and they have to repay those loans plus interest.
That's correct.
Okay. At the same time, the ACA cuts the amount of reimbursement and cuts the amount of payments both through Medicaid and through Medicare that physicians can charge for providing services.
That's not correct. It does not deal with physician payment. There are some cuts to hospital payment. Physician payment has been independent. It's been handled through something called the Sustainable Growth Rate Formula that is part of the 1997 Balanced Budget Act. There were some enhancements to physician payment in the Affordable Care Act, but there weren't any cuts. But Congress has continued to struggle with these cuts that have been in place since the 1990s, and it looks like now they're finally figuring out how to work around them. But it's a huge problem. I mean, we're talking about a couple $100 billion to solve.
Yeah, and the bottom line of that problem is physicians can't make enough to sustain a lifestyle, should we say, worthy of a physician, worthy of those 12 years, 8 years, whatever they're doing of school, and to repay the loans and the interest which they are entitled to through the ACA. So, I mean, while the intent may be laudable, the math doesn't work. The records I have here is that they have less than 1,400 people enrolled in the physician side of that title to the Act over a 3-year period. And, you know, correct me if I'm wrong.
Well, I don't know the exact numbers, but I do know there's been some problems with some parts of the statute were not fully funded by Congress, and Congress isn't real excited right now about appropriating more money for the Affordable Care Act, at least not the House side. So I think part of the problem there is that you know, there were parts of the statute that have not been implemented yet because of problems with Congress funding it. As to your first point, though, I mean, I think you're right, and I think one of the real fundamental problems here is a really different problem that you probably won't want to talk about today, and is way beyond the scope of what I have to say. But that is income disparity in the United States. We lived in Germany at one point. My wife had a very, very serious accident. She was in the hospital for 2 weeks, had 4 surgeries. The total bill was about $10,000. And when we came back, had a minor outpatient surgery that took a couple of hours, and the bill was almost twice that. But we talked to the doctor there who had done the work, who was a very highly skilled hand surgeon. This was a university hospital. He did a 7-hour operation under a microscope. And And he said, I have friends who graduated from here. They've gone on to the United States. They make 3 times what I do. But I make a very comfortable living for here. I've got a good car, a good house. I've got everything I need. In the United States, a physician looks at the stockbroker living across the street who has far less education, probably knows a whole lot less, and is making a whole lot more, and thinks I'm really entitled to make a whole lot more than I'm making here. So, and they should be well compensated for their skill and their training. But I think we are reaching the point where, as a society, leaving the Affordable Care Act aside, we can't afford to spend so much more than any other country does in the world on health care, so we have to figure out, where do we cut? How do we pull back? And frankly, I don't think the right way to do it is just by denying 50 million Americans access to health care at all, and the rest of us will have good health care.
Okay. Well, but the bottom line is, if they have access to health care but the providers are not there for them, then they have no health care.
Well,
if you're starting off with a doctor shortage and you're only adding, let's just take the last 3 years as an average. I'll tell you what, let's double it. 1,500 new doctors enrolling through that title of the ACA every year. All you got to do is do the math, and we're in a big hole. A lot of projections say 125,000 doctors by 2020. I don't know. I'm not in the industry.
Yeah.
But I think there's widespread agreement that the doctor shortage, primary care physician shortage, is going to increase rather than decrease, at least for the next decade. And if you can't get in to see the doctor, you can't get in to see the subordinates, the nurse practitioners, etc., then that health insurance is not doing you any good whatsoever.
So is the solution to that then that we let rich people in and tell poor people you can't see a doctor at all?
No, I don't think that's the solution. I think my personal opinion is the solution is you get rid of this law, which is a monstrosity, and you start over with 200 pages because you can, through the market system, you can revamp this healthcare system, make it better, have not only access for many more, in fact, probably more than you would have under the ACA, given the IRS study, but you would also additionally have care providers for them, because the care providers will have incentive to spend their 8 to 12 years in school and their $100,000 to $200,000 in tuition and other costs. It all comes down to incentive, not disincentive.
Well, I absolutely agree with that, and that's what the Affordable Care Act does. It's pouring more money into the system. It's getting more people covered by health insurance.
Yeah, but let's step back.
Where
does the money come from? Timothy, where does the money come from?
The money in the Affordable Care Act comes from lots of different sources. Some of it is just reallocation of money that we're already spending.
Well, that's $715 billion from Medicare.
Yeah,
correct?
It's reallocation of money from Medicare that has been, for example, a lot of that money goes for what are called disproportionate share payments, and those are payments to hospitals that care for the uninsured. Well, if we can get people insured, we don't have to pay hospitals anymore to care for people who are uninsured. Some of it is money that has been spent on Medicare Advantage plans, which have been paid 14% more per Medicare beneficiary than traditional Medicare spends.
Which people will now lose. The Medicare Advantage, that's going to go away, correct?
Well, actually, Medicare Advantage enrollment has grown since the Affordable Care Act went into place. And
but once the Affordable Care Act is fully implemented, Medicare Advantage goes away.
I don't think so. I think that the plans are just going to be more efficient. So far it's been growing since the Affordable Care Act went into effect, and I don't see any reason why it won't continue to grow. Now, the other money, some of it comes from, for example, imposing Medicare tax on unearned income. I've always thought it was crazy that somebody who is out there working at a fast food joint is paying Medicare taxes, but somebody who has billions of dollars and is living off of clipping coupons doesn't have to pay any Medicare taxes on their investment income. So it evens that out for people who have incomes above $250,000 a year.
Stop. We need to stop for a moment. Let's step back. Let's look at the big picture of the costs. We've talked about access, and I think, we agree on some points, don't agree on others. But let's talk about cost.
Mm-hmm.
Now, the president promised us a cost of what when he was selling us this bill? It was $940 billion. That was his promise.
Mm-hmm.
And it was funded. We've already talked about part of the funding, $715 billion, should we say, reallocation from Medicare. And by the way, the AARP disagrees with you. They say Medicare Advantage is being phased out, and they are willing to step to the plate and sell you insurance to take care of that Medicare Advantage you're going to lose. I don't think much of the AARP, but that's their position. So we then have $675 billion in new taxes, which began January 1. We were promised, I think the exact words were, not one dime from anybody, $200,000 as a couple, $250,000 as a couple, $200,000 as an individual. Not one dime of new taxes would assault your pocketbook. Yet $480 billion of those 21 new taxes affect people under $200,000. So this 250 number is just flat wrong.
Yeah, I haven't looked at the financing recently.
Okay, but if you take those two, without getting down in the weeds and who's paying and who's not, they only come.
And there are things like the tanning tax that I'm sure affect people who earn less than $250,000. So.
Yeah, well, that's minor. I mean, the others are far more significant. However, I don't want to get down in those weeds right now. The bottom line is we were sold a bill of goods, and the bill of goods is false.
No, I don't agree with that. I mean,
if we were promised that nobody under $200,000 as a couple, as an individual, or $250,000 as an individual would pay one dime. That's the exact quote. You can Google it up right now and watch him talk on the video. Will not pay one more dime, not one more dime. That's a lie. There's $480 billion of that $675 billion that is being paid by people under $250,000 or $200,000 respectively in income.
What are some examples of those taxes?
Well, number one, you had the medical device tax, which basically reaches into everybody's pocket. Number two,
the medical device tax. Let me explain that because I think there's been a lot of.
That's okay because it's been thrown out by the Senate. It was a 78 to 20 vote, so it's gone. So that's one tax. We're now down to 20 taxes. I'm not sure they did it out of any concern about the populace. They did it out of concern for their medical device manufacturer lobbyists. But notwithstanding their motivation, it's gone. The other taxes in the law range all the way from 3.5% transaction taxes, which affect capital gains, which, you can be making $50,000 a year. You can have paid off your home. You can have bought your home 30 years ago for $20,000, and even with the current, shall we say, softness in the real estate market, it might be worth $100,000, and you're going to get taxed on that.
That's not true, actually. That's not true. The 3.5% tax only applies to capital gains on investment income of people making more than $200,000 as an individual or $250,000 as a couple.
No,
and No, you're wrong. It does not apply to the sale of homes, except under very rare circumstances. There are separate laws that deal. No, this is something that's been going around on the Internet, and it's just not true.
But I'm not done explaining it.
Okay.
They have two catches in there. It's kind of like the alternative minimum tax. If they don't grab you with the alternative minimum tax, which, by the way, Obamacare reinstates, if they don't catch you with the alternative minimum tax rather than the income tax, and they don't catch you on the 3.5% transaction fee because you haven't met the income thresholds, there's also a limit as to how much you can make, and it's far less than $200,000 before you're hit with a transaction penalty. So
that's
it's
not
either
my
or.
understanding. I double check that because this is something.
Well, I'll tell you what. The sites for everybody who wants to, because I don't want to spend too much. I really want to give everybody a big picture here.
Sure.
And I think we're doing it by where we agree and where we don't. But on the rightsideradio.com, folks, go back about 4 months. I did 2 shows on all the taxes in Obamacare right off the IRS sites, right out of the bill, and with 2 tax experts. You can hear about every single one of the 21 new taxes. You can determine which ones affect you and how much yourself. So why don't we agree, Timothy, that some taxes affect people below 200 and 250,000. We can disagree on how much. We can disagree on what they are.
Yeah.
Okay.
Yeah. No, I think that's likely to be true.
Okay.
But I think most of them do not.
Because when you get down to the bottom line, you have a bill that's going to cost, by CBO estimates for 9 years, $1.7 trillion. By CBO estimates, you can look at their 2012 study. In the 10th year, which they omit from the previous studies, quite clever, 10 years of revenue, 9 years of cost. In 2022, they're showing an annualized cost of $265 billion a year. Now, when I multiply that number times 10 years, I come up with $2.7 trillion. Yet we only have funding in this bill, whether you want to go with the $1.7 trillion figure or the $2.7 trillion figure, of $715 billion and $675 billion. And last time I checked, it's less, way less, than either one of those 2 numbers. So where is that extra, let's take the low number, $400 billion, round numbers, or the high number, $1.2 trillion, where's that money going to come from?
Well, once again, I have not spent much time on the finances of this since the bill passed. I'm really dealing with the implementation.
The policy stuff?
But the last time I looked, the CBO's baseline study for 2013, they still showed it as reducing the deficit over the next 10 years. Now, beyond
I understand. I know how they got their math, and their exact number is $104 billion.
Yeah. But the other thing on that is, well, go on.
Yeah. Understand that that's based on a 2012 to 2021 projection. All you got to do is look in the fine print of their study. And they leave out 2022, which is in their 2012 study, which gives you a decade projection of $2.7 trillion. I mean, I'm just pointing this out to people because there's all sorts of hanky-panky, and I'm not blaming left or right. I think there's hanky-panky on both sides. But there's all sorts of hanky-panky with these numbers because they're huge numbers, and it's a complicated deal, and it's real easy to confuse people. The bottom line is that the funding for this bill, which was promised to be a cost of $940 billion when it was passed, is now somewhere between $400 billion and $1.3 trillion short. And I don't care what the CBO says about the budget, the fact that we're going to reduce the deficit by $104 billion. When you reduce one side of a ledger by $104 billion, and you do it by taxing the population who owns the ledger $1.2 trillion, there's no reduction at all to the guy on the ground.
Hey,
the government is not some separate entity. The government is us. And in my world, I'm a rancher. If I sell a cow for $10 and it costs me $120, in my world, I lost $110. Even if my balance sheet improves by 10.
Yeah. But, I mean, there are lots of other factors in this equation, like the fact that if you look at baseline Medicare costs, those are growing at a much lower rate than were initially projected, and some of that has to do with the Affordable Care Act. So it's not just raising revenue, it's also cutting expenses, and that contributes to balancing out the budget as well. And, of course, the deficit is much more attributable to Bush's tax cuts and a couple of unfunded wars than it is to the Affordable Care Act. But that's
I think the deficit is. We'll take a step back here. Put on the boxing gloves for 10 seconds. I think the deficit is a combination of Bush being a moron and Obama intentionally spending us into oblivion. Bush to the tune of $5.2 trillion over 8 years, and Obama thus far $7 trillion over 5.
Yeah,
so
well, that was...
you don't want to know what I think about either one of them on that score.
Yeah. Okay, let's then get back to health policy.
So anyway, the bottom line here is that we have a bill, and I don't care where you go. You can look at the IRS study, you can look at the CBO study, you can look at the GAO study, and if you sit down and you do the 10-year numbers, or you do their 9-year numbers with 10 years of revenue, you are hundreds of billions to $1 trillion short. And that money has to come from somewhere. And I think you'll agree with me that the only sources of money for the government of the United States is the pockets and property of its citizens. Is there any other source of revenues?
Well, yeah, I mean, we raise taxes, and we do it because it's the cost of a civilized society, and I think the question that I'd like to talk about is, are we living in a civilized society when 55 million people are uninsured? Are we living in a civilized society when we spend far more than anybody else in the world does on health care and aren't getting value for it? And so that's what the Affordable Care Act is attempting to address.
And you know, and
obviously
you
covering
you and I,
30 million people is going to cost the money.
And listen, you and I, yes, and my concern is you have a doctor shortage now, and now you're going to bring 30 million people onto the rolls. Mm-hmm. In my world, that's going to reduce the quality of care for everybody. Okay, in your world, it's a good thing. You know, who knows which world is correct?
I think in my world, if I have access to health care and my neighbor doesn't, to me that's a moral issue. And if I have to share a little bit, if I have to wait a few minutes longer in the doctor's office, that's a price I'm willing to pay to live in a society where when people get sick, they can get health care.
Well, we're not talking about a few minutes. Are you familiar with Canada's system? Are you familiar with England's system?
I've lived in England. I've been in their healthcare system. I have lots of friends in Canada. I've lived in Germany. I've been in their healthcare system.
And what is the average wait by a Canadian citizen for a non-life-threatening but nonetheless important life quality operation?
The average wait in an emergency room, as I believe,
not an emergency room.
United States. Well,
I'm talking about somebody who.
If you want a hip replacement in Canada, it takes a while longer. If you need,
by a while longer, let's quantify that. The wait time is between 9 and 14 months, depending upon the province. What is the wait time in the United States if you want a hip replacement?
It depends on how much money you have. It can either
let's
be
assume
forever,
you have money.
it could be probably a week if you have enough money. But
right.
Assuming you have the money is the basic question. If you don't have the money...
But in Canada, it doesn't matter if you have the money or not, because if you have the money, you're going to come to the United States to get that hip replacement 1 year early. And, if you're going to stay in Canada, you're going to be stuck with 1 year, and it doesn't matter how much you have.
In Canada, I'd have to check your statistics because I know that they have been working on those issues and that.
Well, that's right. They've been scaling back the socialistic aspect of their health care law, strengthening their dollar. Their economy is far more stable than ours, and their health care system is finally getting back into balance as they privatize what they originally socialized under the NDP 16 years ago. I'm very familiar with Canada. We've had ranches up there.
Yeah.
So, the bottom line is I agree with your goals. Mm-hmm. Your goals are laudable. The problem is that I don't believe that this bill is the way to do it. In fact, I think this bill, in the end, will undermine the goals we both share. And it will undermine it in a number of ways. Number one, and I want to talk to you about these. I'm not preaching. Number one, it doesn't pay for itself. It has to pay for itself. Number two, it does not provide access for everyone, and it should. I mean, to do this kind of revamp, to go $400 billion to $1.3 trillion in the hole, which all has to come out of our pockets in one way, shape, or form, and still have 30 million people uncovered is outrageous. And number three, the way this bill was done, and we're going to talk a little bit about this in the last third of the show. This bill was done, how do I phrase it? This bill was not done to better health care. It was done to increase control. I have a real problem with increased government control. For instance, let's talk about the IPAB for a while. You know, the people on the right scream death panels, and the people on the left scream no such thing, that doesn't exist. You and I both know there is an IPAB. And you and I both know that the IPAB will, in the end, determine kind of, should we say, the base level of goods and services that can be offered to varying age groups and productive members of society, you know, based on a...
Actually, both of those statements are not true, and I don't agree with them.
Okay,
Number one, we don't have an IPAB.
Tell me what
we
the
don't
IPAB
have an
does.
IPAB. We don't have an IPAB right now.
No. Oh, no. Don't look, Timothy. I have a lot of respect for you. I'm not talking about right now. You talked about the title that's supposed to promote doctors, which obviously, with 1,400 enrolled over 3 years, is doing squat. I'm willing to give you that in the future it's going to do better. We don't have an IPAB right now, but in that bill is the IPAB. Is that correct?
There is,
and we will have an IPAB by 2016. Is that correct?
No, I don't think we will.
You don't. Do you think Obama is going to unilaterally disband the IPAB also?
No, he has to appoint members of the IPAB. He hasn't suggested any names yet.
Okay, so there is an IPAB.
And the Senate will never confirm them. No, there is not an IPAB right now.
Okay, but there is an IPAB in the bill.
There is an IPAB in the bill.
And that's
now, in terms of what the IPAB...
Go ahead.
Excuse me? In terms of what the IPAB does, what the IPAB does is if the CMS actuary projects it 3 years out, there are going to be increases in the cost of the Medicare program above a certain level. The IPAB's job is to come up with proposals that will reduce the cost by a certain percentage. And then those proposals are submitted to Congress.
How does it reduce the cost? Let's stop there. How does it reduce the cost, Timothy?
It's probably going to reduce it by reducing payment levels.
And which is not going to help you bring in more doctors, right? Because doctors are going to make less.
Well, it's probably going to reduce it primarily by reducing payment levels to pharmaceutical companies and to others. But it could.
Well, who are the others? Hospitals?
Yeah. Well, hospitals are exempt for the first few years because they.
Look, there's a whole bunch of stuff in this bill which exempts and waives and does all this kind of crap for the first 3 or 4 years, just to get us through a couple of election cycles, so it can kind of implant itself like.
Well, no, there was a reason. There was a reason for this.
Well, yes, and you'll think that it's good, and I'll think it's political.
But I'm not a big fan of the IPAB. But the IPAB is in there for a reason, and that is, and you've already identified what the reason is. Mm-hmm. Every time somebody has proposed a way of trying to save money in Medicare, people like the medical device manufacturers run down to their congressman's office and they say, no, you can't possibly hurt us. So Congress has proved itself pretty much incapable of, there have been a few exceptions, but pretty much incapable of holding Medicare costs in line. The Medicare, as you've said a number of times, we can't write a blank check for Medicare. We have to pay for it somehow. So let me finish. Hey, let me finish. What?
All right, I said, or for the ACA. I mean, we just don't have blank checks to write.
Well, Medicare is a large part of the ACA is Medicare. And so the question then is, how do you control those costs? And what the IPAB in theory does is it says to Congress, look, if you can't do the job, here's a proposal. If you can think of a better idea, then you do it. Otherwise, this proposal is going to go into effect because so we have to have a grown-up in the room. Somebody has to control healthcare costs.
And do you think a grown-up is 15 non-medical professionals appointed by the president?
Some of them will be medical professionals, but
let's assume they're all medical professionals appointed by the president. Do you think that's a grown-up?
I think they would do a better job than Congress does because they are not going to be listen to everybody who comes in the door waving money in their face.
And listen, and that's a good point. And that's, you may have a point there, but if you go one step further on the IPAB, the only way you can cut costs is to either limit payments or limit services.
And
or both.
The statute prohibits them from limiting services, so the only way they can do it is limit. The statute explicitly prohibits them from limiting services, so the only way they can do it is by limiting payments. But let me just say, I'm not here to defend the IPAB. I've written articles about the IPAB as to why I don't think it's a good idea. I think a much better idea is the Medicare and Medicaid Innovation Center, where they try to come up with long-term solutions that bend the cost curve rather than 2 years out we're going to be $1 billion over and we've got a whack.
Yeah, we're in complete agreement.
Okay, good.
Way better. We agree already on what I would call a 6-point plan to get rid of Obamacare and replace it with something that actually accomplishes the goals you and I share.
Well, except the Innovation Center is part of Obamacare. I mean, what happened is that the Affordable Care Act...
Here's the big problem, and I'm going to speak as a conservative, and I'm going to chastise my own. You can't run around talking about defunding and repealing and this and that and this and the other unless you have a plan. And my side is seemingly incapable thus far of coming up with a cohesive plan. And it's outrageous. And it pisses me off as much as the drum beating on the other side. I mean, I am first an American. And, not doing what's right for the country, I don't care if you're lefty or you're righty, it kind of sticks in my craw. So it's really interesting that two people here on this interview, and hopefully the audience is getting something out of this, who I think may have some fundamental ideological differences, nonetheless agree on some fundamental and universal goals. And it's just a question of how to reach them. And what pisses me off, and I'm sure it does to you too, because I think you really care about this, Timothy, is when people only want to attack, don't want to construct.
Yeah, and I think the problem is, I think one thing about the Affordable Care Act, and it has something to do with the way in which it was drafted, is that they basically, as you said at the beginning, it's about 1,000 pages long in regular statutory text. In the big print, large margins version, it was 3 times that long. But it basically, there's every idea in there that anybody who thinks about health policy has come up with in the last 10 years.
Right.
You like high-deductible health plans? They've got high-deductible health plans, and I think many people are going to be surprised how high-deductible these plans are that are going to come through under the Affordable Care Act. You like competition? There's managed competition where we try to get insurers who hate like everything to compete with each other. They want to be monopolists, but we try to make them compete with each other. Will it work? I'm not sure, but the idea is let's get some competition going.
Well, see, unfortunately, and see, you and I agree on that too. I mean, I take it you like that concept.
I would like to see it work. Yeah.
Yeah. Okay. Well, see, we agree on that universal goal.
The problem is a lot of people who talk about...
I think the insurers should be allowed to go out there and just beat the hell out of each other. But you know what? Here's one thing that's not part of Obamacare that could be part of a replacement bill, and that is insurance across state lines.
That's in there.
No, it's not.
Yes, it is.
It's not.
It's not there until 2017, but it's in there. But let me just say something to that, and that is that Georgia decided this is a great idea. They opened the doors, said, all you insurers come in here.
Yes,
and nobody showed up.
And nobody showed up. And then in California, 4 of the 7 just dropped out. Humana, Aetna, and the other 2, I forget their names. I mean, they just dropped out of the damn exchange.
Well, some of the big insurers are sitting on the sidelines for the first year or two because they want to see how things go. I'm a consumer representative to the National Association of Insurance Commissioners, and in fact, I'm about ready to leave for a week of their meetings, which, believe me, are not the most stimulating places to be. But you talk to insurers a lot, and they don't like risk. they don't like to get into a situation where they don't know what's going to happen next.
Right.
And that's what's happening right now with the exchanges, because if only, everybody's holding their breath, if only old sick people show up, it's going to be pretty hard to cover these people for a reasonable cost. But those, of course, the people who really need coverage. But if some young, healthy people show up, and they really need coverage too, the highest incidence of use of emergency rooms.
You and I agree on that also. But
we've both had kids. We know how much they use emergency rooms.
Listen, and it's one thing after another. From turning over ATVs and falling off of horses, you just name it. If they can dream it up, they'll do it. But
I'm in the lower risk part of the country for raising children. But go on.
Well, don't worry. That'll probably change. One of the things which gives me quite a bit of angst is that I think we both agree that the aging portion of the population obviously needs more health services overall.
Right.
Never mind accidents. Overall, than the younger portion of the population.
Mm-hmm.
And you have, we disagree a little bit on the, shall we say, the parameters of IPAB, and we've talked about that. Not all of that $715 billion Medicare cut was simply, shaving this and shaving that. Some of it was, in fact, taking funds out of care, what I call care monies. And that Medicare program benefits a lot of people, but primarily it benefits older people. And then, when you couple the fact that the way this was designed, I mean, it's kind of like the same paradox they got themselves into, saying, okay, we have a doctor shortage, we're going to have incentive for doctors, we're going to loan them the money, but then we're not going to pay them enough to repay the money. How come we don't have any doctors? What's going on now is that the premiums for young people are going through the roof. There was a recent study, last week, I think Indiana is projecting an 89% increase in premiums for people under 40. Nevada.
Yeah, the numbers are kind of funny in Indiana. That was a statement that was put out by the governor, but if you look behind it, they are comparing apples and oranges, and they're comparing cantaloupes. And
how about Nevada at 101%? Or Florida at 35%?
If you look what's happening is the blue states are coming in with either decreases or very good comparable rates. The red states, and what usually happens is the governor or the insurance commissioner puts out a press release with a single number, and the states you just named, are all states where it's not to the political advantage of the governor and the to say Obamacare is really working out well for you.
Okay, well let's talk about
there's
California.
A lot of spin going on here. If you look at the actual rate
cost, the average cost for insurance in California has gone from approximately $9,000 to just under $17,000 for a family of four since the ACA was passed. And perhaps you could tell us what the costs are projected to do in California. By the way, 60,000 people just lost their coverage in California. But tell us what the costs are projected in California, let's say.
Yeah, I don't have those numbers at my fingertips right now.
Well, they're projected to increase. I'm familiar with the numbers that New York sent out, saying that they were expecting 11%, or maybe it was 14% decrease. Whatever, it was a decrease.
It was 50% decrease. But yeah, there are some peculiar things about New York and their insurance market that make that happen. New York is a one-off. But
right.
The other thing is that, again, the employment-related premiums went up only 4% for individuals, 5% for families this year, compared to 9 and 10% increases that we were seeing.
No, I understand, but many people's
if you compare over any period of time, you're going to.
But many people's premiums have doubled. I mean, the IRS study says $20,000 for an average family of four by 2020. I mean, this is the government itself. So there's some scary things out there, and believe it or not, we got like 3 minutes left of this show. It's gone really quick, and it's been, by the way, a great discussion I'm delighted we agree on some really key issues. And here's what I want to ask you, because I want to leave things on a really positive note for people. Assuming that, somebody somewhere has the balls in Washington, D.C. to form a bipartisan whatever and come up with a good plan that will actually achieve the goals that you and I want to see achieved. What are the 5 elements that must be in that plan in your mind for it to work from an economic standpoint, from an access standpoint, and from a quality of care standpoint? I mean, if they went to you right now and said, you know what, ACA sucks, Timothy, you're in charge, draft a new bill, what are the 5 key points?
Well, in the first place, in 3 minutes, I can't possibly say. In the second place, if I had been in charge, and the second place, it's never going to happen. Congress is so toxic right now that they can't agree on anything. I imagine they're going to stop, proclamations of National Dairy Week soon. Have filibuster.
And I'm sure Obama will keep stirring the pot to make sure they don't.
But the third thing is, where I think we went off the beam to begin with, was we had a problem of a large number of people who were predominantly lower income, not predominantly, but many of them unhealthy, unable to find private health insurance, not insured through the employment market. And what the Affordable Care Act tried to do, because many of the people who drafted it were from your listening area, was to come up with something that would preserve our private health insurance system. What I think they should have done was to just say that we've got a great employment-based system, we've got a great private health insurance system, God bless them, they're not going to solve this problem. So let's figure out how to solve it. And what I think that would have looked like would have been a public program based primarily in community health centers with contracts with hospitals, and it would have focused on the problems of the population that needed help rather than trying to deal with the entire healthcare system. The problem is that once you do that, then some employers are going to say, hey, I don't need to do this anymore. People can get insurance privately. And private insurers are going to say, let's take the healthy ones and leave the sick ones to the government. And pretty soon you have our current system kind of crumbling. And so what I think they tried to do through the Affordable Care Act was to build on our current system and to make it work better. And the problem is our system is so complicated, and they added so many complications to it that
they didn't simplify.
I look at it at the 100-foot level every day, and it's pretty hard to see how everything is going to come together here.
Yeah. What do you think? By the way, this is going to be my last question for you. What do you think of Obama's? He has now delayed close to half the provisions that were supposed to be coming into effect here over the next 6 to 12 months. Do you have any opinion on that?
Well, I think that, and I talk to these people regularly. They are trying their best to deal with what Congress dealt them, and trying to figure out what can we do now. And another thing is they are absolutely. Let's be fair, though.
Absolutely
starved for resources. What
the Democrats dealt them, right? There's not a single Republican vote.
No, what the Democrats dealt them, but I should say the Republicans have absolutely starved them for resources. So they're trying to implement a very complicated bill on a shoestring. And frankly, I think they're doing about as good as they can do. They're saying, look, we've got to do this right now because this is at the heart of it. This we don't have to do right now. We don't have the resources to do it. We don't have the money. We don't have the staff. We'll do it next year. So, and by the way, administrative agencies do that all the time. This isn't anything new.
Actually, there's a budget process. There's also this thing called the Constitution, and once a statute is enacted, under the Constitution, the President does not have the constitutional authority to just ignore, delay the law without going back to the legislative branch. But that's a whole civics question, which is not the purpose.
A lot of presidents have done that, and it goes all the way back to Marbury versus Madison. That's what that case was about. It was
and you know what? I have the same remedy for all of them, but I won't say it on air.
Okay.
Anyway, this has been a terrific discussion. It really has. It's been great. And I want to thank you very much for kind of
coming in for inviting me and
to the Lion's Den. I hope people got a much better feel for both facets of thought here, and I'm sure they did. And, we will reconvene, if you'd like to, Timothy, maybe 6 months and see where this thing's at. And, maybe some brain cells somewhere, although I have the same doubts you do, will start to function in Washington, and we'll be able to talk in enthusiastic and mutually optimistic terms.
Okay, well, we'll see how it goes. But thank you for inviting me, and God bless everybody in your listening area. You've got a beautiful part of the country there.
Thanks for your hard work on things.
Thank you. Good talking.
Bye now. Bye now. This is Reid Lance Rosenthal on the Right Side Radio, folks. I think that was a pretty good interview with lots of thought-provoking stuff. And get your friends to listen to it on the archives. Those of you who are not listening to it on AM. And also listen to last week's show, which was a different set of facts and circumstances surrounding Obamacare, and go back into the archives and listen to that whole show I did on Obamacare taxes. I think you'll find it interesting. And in the meantime, you have a great Saturday. I'm going to be in Thornton, by the way, tomorrow, Sunday, book signing at the Barnes & Noble in Thornton Creek Barnes & Noble, so come on down and say hi. Have a great Saturday.